Thank you much for the invitation. So my topic was the use of intravascular imaging in the setting of acute coronary syndrome. Does everyone need a stent? An interventional cardiologist is what we train to do, to put in stents. So let's see when we have to hold our fire and not actually place a stent. So that was my disclosure slide. So when we are faced with a patient coming to the cath lab with chest pain, troponin elevation, ECG changes, acute coronary syndrome, the usual underlying pathology is that of an advanced coronary atherosclerotic lesion together with acute thrombus formation. And we know that stenting of these lesions is indicated to reduce the future risk of myocardial infarction and death. And we've learned from OCT and IVUS that the major culprits that we see in imaging are predominantly plaque rupture, less frequently coronary erosion, and occasionally calcified nodules. And when we do detailed imaging analysis of these culprit lesions, what we can see is that from a severity perspective, usually these are angiographically and image-related severe lesions with small area, residual area, lumen area, that they have extensive plaque, both calcified and fibrotic, as well as lipidic, particularly lipid-rich in the case of plaque rupture lesions. And that regardless of the amount of angiographic thrombus burden that you might try to appreciate on a luminogram by intravascular OCT, in almost all cases, you're going to see thrombus in these sorts of culprit lesions. But not all acute coronary syndromes are related to atherosclerotic plaque and thrombus. And there's a differential diagnosis that we need to consider. These cases will lack the presence of thrombus or the presence of an advanced atherosclerotic lesion, or possibly both, and can be managed in general without stenting. To help you see these, let me go through some case examples. So this is a patient whose angiogram shows a moderate stenosis in the first obtuse marginal branch. He's a 36-year-old fellow who came into the cath lab with new chest pain and ST elevation in the infralateral leads. But what's surprising clinically is that the lateral segment of the myocardium, as you see in the LAO view ventriculogram, does not actually show a matching wall motion abnormality. So the patient has an angiographic finding that suggests that maybe they're having a STEMI, but the wall motion doesn't match, and the ECG adds confusion. So doing intravascular imaging here is very useful to know whether actually a stent is needed or not. And in this patient, we do see that stenosis in the circumflex was a significant atherosclerotic lesion with fibrocalcific plaque and some lipidic plaque as well, but there's no thrombus and there's no acute plaque disruption. This patient was managed without a stent, and the discharge diagnosis of myopericarditis was consistent with the fact that he had only a mild troponin rise and that his chest pain resolved with treatment with non-steroidal medications. Here's an example of a patient who's 72 years old, has had recent knee surgery, and following this surgery, she had an elevation in her biomarkers, was diagnosed with a post-op myocardial infarction, and came to the cath lab. I hope you can appreciate in the mid part of the LAD, there's a hazy stenosis. Again, angiography is indeterminate as to what this is. Is it a focal calcified nodule? Is it intravascular thrombus? We need intravascular imaging to achieve a confirmed diagnosis. And what do we see when we apply intravascular imaging in this case of acute coronary syndromes? We see that there's actually a substantial thrombus in this artery, but the underlying artery has very minimal disease. And once thrombectomy was done to remove that clot, the underlying vessel shows only very minimal atherosclerotic disease. This is not the substrate in which a local thrombus would have formed. We felt very confident to make the diagnosis of an embolic myocardial infarction, and the patient was treated without stenting. Last case, this is a 70-year-old female with anterior myocardial infarction, a ventriculogram that shows anterior apical and infraapical wall motion in keeping what would be likely a Takotsubo cardiomyopathy based on the ventriculogram alone. But then you're confronted with this angiogram, which shows a moderate to severe proximal LAD stenosis and a wraparound LAD anatomy. Could this have been a thrombus in the LAD that lysed and produced that kind of a wall motion abnormality? We certainly wouldn't want to send a patient with an acute LAD plaque home without a stent if that's the degree of wall motion that they acquired. Once again, intravascular imaging is of great value here. We performed intravascular imaging in this case and showed that there was an atherosclerotic lesion, as you would have suspected from the angiogram, but we were very confident that there was no intravascular thrombus, there was no disruption of any of the endothelial surface, and confirmed the diagnosis of Takotsubo, which we realize requires us to confirm that there is an absence of plaque rupture or thrombus. This patient is a 43-year-old lady with no previous cardiac history or vascular risk factors, comes to the cath lab with anterior STEMI that is resolved spontaneously prior to the angiogram. An echocardiogram had been performed, which showed normal ejection fraction and a mild increase in her troponin. You can see on the angiogram the moderate mid-LAD stenosis. Intravascular imaging in this patient shows the absence of both thrombus as well as atherosclerosis. This patient has, as you can see on the OCT, an intramural hematoma, and the diagnosis is spontaneous coronary artery dissection. The absence of these findings, of course, leads to the decision not to place a stent. And we recently collaborated with a number of Canadian investigators to collect a large prospective series that was published in the European Heart Journal earlier this year of 750 patients with spontaneous coronary artery dissection. The mean age in this registry was 52 years of age. Many patients present without any cardiovascular risk factors. 30% of them have ST elevation at the time of presentation, and 70% present with non-STEMI. Intravascular imaging is actually used relatively uncommonly in the diagnosis of SCAD because usually you can pick it up on the angiogram, and it's better to avoid instrumenting the artery wherever feasible. And it was performed uncommonly in this registry as well. And you can see on the right the initial management of these patients. It is appropriate to manage SCAD without a stent in the vast majority. Conservative management was used in 86% of patients. And with that management approach, the 30-day event rate observed in this registry was a death rate of 0.1% and a recurrent infarction rate of 6.7%. Now, occasionally your hand is forced, and one of the patients that was enrolled in this registry was one that we put in, the one I just showed you, who then came back 4 days later to the cath lab with recurrent ST elevation, has now a progression and occlusion of the mid-LAD with TIMI zero flow, ongoing chest pain, and ST elevation. So not all patients with SCAD require a stent, but sometimes you do have to intervene. This patient then had the vessel wired. We did a cutting balloon to try to decompress the hematoma, but the patient still had ongoing chest pain and poor flow, and finally stents were implanted with a good result, and she did quite well. So the message is that vast majority of patients with SCAD don't need a stent, but some might. Now that we're all looking for spontaneous coronary artery dissection very carefully on our angiograms and trying to make this diagnosis and not miss it, sometimes we overcall it. This is a 29-year-old patient who had an angiogram for an NSTEMI with a background history of diabetes. The angiogram shows this stenosis in the proximal LAD, which was diagnosed by angiography alone at the time as showing a type 3 SCAD. Unfortunately, the patient then presented 2 months later with recurrent chest pain and ST elevation. The angiographic appearance is stable, which of course is atypical for SCAD, and you can see the severe proximal LAD stenosis. This time around, we performed intravascular imaging to assess the diagnosis. And it shows, in fact, that this patient had an extensive atherosclerotic lesion, a severe stenosis that certainly wasn't going to get better with conservative therapy, and she received a stent. Lastly, I'll just close with highlighting this controversy that even in patients who have thrombotic atherosclerotic lesions, we are now starting to ask the question with intravascular imaging, can we defer stenting if there is no plaque rupture? And I'll point to this excellent series of 53 patients that were studied with mostly STEMI who had thrombectomy, treated with dual antiplatelet therapy and no stenting. The follow-up appears to be quite benign in these sorts of lesions, and on follow-up imaging, many had resolution of thrombus just with conservative treatment. I suppose against the gold standard of stenting in ACS, true ACS, this strategy will need to be subjected to randomized trials. In the meantime, I think it's reasonable to use clinical judgment. Conservative management of coronary erosion may be appropriate in a patient such as this. This is a 42-year-old patient with vascular risk factors, non-STEMI. You can see the mild to moderate lesion in the proximal LAD. The OCT in this case confirms a non-flow limiting erosion with relatively modest thrombus burden, and she was treated conservatively in our center without stenting. But a case like this, of course, you would agree with me, probably isn't a candidate for conservative management of erosion. A very dramatic presentation of a 35-year-old patient with anterior STEMI, cardiogenic shock, ventricular fibrillation, re-elevation of inferior ST leads, and now an angiogram and an OCT that actually shows double vessel erosion with both erosions in the mid-RCA and the proximal LAD. Of course, this patient received stenting. So in conclusion, the causes of acute coronary syndromes are most often plaque rupture, coronary erosion, calcified nodules, but there is a broad differential diagnosis. Angiography does not tell the whole story. Not every patient needs a stent, but every patient does need a diagnosis, and do use OCT where appropriate. Thank you.